Thank you so much for kind introduction, Dr. Bae. Today, I'm going to review the anatomy of a conduction system in different type of congenital heart disease, which may provide basic knowledge to understand the arrhythmia in adult congenital heart disease. As you know, cardiac conduction system is composed of a sinoatrial node as a pacemaker, atrioventricular node for atrioventricular delay, connecting to atrioventricular bundle and right and left bundle branches and Purkinje fibers. At the right atrial, this picture shows the lateral view of the right atrium. SA node is located between entrance of a superior caval vein and the right atrial appendage at the subepicardial side of the upper part of the sulcus terminalis. The endocardial view of the right heart shows the cos triangle limited by tendon of Todaro, coronary sinus opening, and the tricuspid annulus. The apex of the triangle is the central fibrous body, and atrioventricular node is here illustrated in yellow in the triangle. Then AB node is connected to the atrioventricular bundle running through the congenital central fibrous body, which is the only portion to connecting bundle branches in the ventricles. From now on, let's talk about the conduction system in the heart with congenital heart disease. As mentioned before, SA node is positioned at the junction of the superior vena cava and the right atrial appendage in the usual arrangement, as well as the corresponding area in mirror imaged atrial arrangement. In the case of right atrial isomerism, bilateral sinus nodes are encountered at the junction of the superior vena cava with the atrium both sides. In the left isomerism, SA node is found in less than half of the hearts. They are always hypoplastic and abnormally positioned in variable areas, usually close to appendage or superior caval vein. The right picture shows the heart with the left-sided juxtaposition of atrial appendages. So right atrial appendages is also positioned left side next to left atrial appendage. The diagram in the center depicts the position of the SA node in this situation. SA node, in some cases, are positioned normally, but in the other cases, SA node displaced in the anterior wall of the right atrium. Then let's move to the atrioventricular conduction system. In order to find out the course of the atrioventricular conduction system, we have to check out some questions. What is the arrangement of the ventricles? And atrial septum and the ventricular septums aligned normally or malaligned? Does the ventricular septum meet the cardiac crux? First group is the congenital heart disease with normal septal alignment, which includes ventricular septal defect, TOF, and atrioventricular septal defect. The first one is a ventricular septal defect perimembranous. In the heart with a ventricular septal defect, regardless the subtype, atrioventricular node is located in the normal position. But the atrioventricular conduction axis, including AB bundle, is differently positioned according to the subtype of VSD. This picture shows ventricular septal defect perimembranous type. The yellow line indicates the location of atrioventricular bundle conduction axis in perimembranous type. The bundle usually lies the left ventricular aspect of the posterior inferior border of the ventricular septal defect. These two pictures shows ventricular septal defect muscular type. This one is trabecular one, and this one is the inlet type. As mentioned before, the position of atrioventricular node is normal, and then the yellow line indicates the location of the atrioventricular bundle and the conduction axis, and running posterior inferiorly to the VSD muscular type, trabecular type, while anteros cephalad relatively to the ventricular septal defect muscular inlet type. In contrast to VSD perimembranous type, the bundle is relatively far away from the border of the VSD, though. Next one is AVSD. This picture shows a heart from the right side, and then there is a big hole at the atrioventricular junction. Even though the atrial septum and the ventricular septum is normally aligned, but the atrial septum premium part is deficient, so does not contact the inlet ventricular septum. And the picture of the left side shows a common atrioventricular junction instead of two separate junctions. Atrioventricular node in this case is displaced inferiorly here, and in this picture is the AV node is here toward to the crux of the heart, where the ventricular septal defect contact with the atrioventricular junction tissue. Because of the location of atrioventricular node and the large atrioventricular septal defect, the AV bundle is relatively long along the ventricular border of the defect. Next is congenital heart disease with malalignment of atrial and ventricular septum. The diagram shows where the ventricular septum is attached to the atrioventricular junction. When the septum goes to the crux, like a normal heart, then we anticipated a regular node in the normal position. But the ventricular septum is deviated like this, then AV conduction tissue is positioned abnormally. Corrected TGA is one of the congenital heart disease which has abnormal disposition of atrioventricular conduction system. Corrected TGA has discordant atrioventricular connection and discordant ventricular arterial connection. With the usual atrial arrangement, there is malalignment between atrial and ventricular septum. So the posterior node indicated in black here, is unable to make contact with the ventricular septum and hypoplastic. So instead of it, the rear acting node is positioned anteriorly, which connects to the ventricular bundle is. The course of the non-branching bundle is very relatively long and encircling the left ventricular outflow tract part, and then anterior superiorly to reach the superior margin of the VSD if present. There are a few variations of the disposition of the atrioventricular conduction tissue in corrected TGA. In case where the pulmonary outflow tract is atretic or narrowed, then the degree of the septal alignment is reduced. In this case, posterior AV node is connected to the AV bundle, or a sling of atrioventricular conduction system connected to both anterior and posterior AV nodes. Another variation of atrioventricular conduction tissue in the heart with corrected TGA is with a mirror imaged atrial arrangement. In contrast of usual alignment, the atrial and the ventricular septals better aligned, so allowing a regularly located atrioventricular node to continue to AV bundle in normal fashion. After giving branching bundles, and then it has further extended to anterior bundle that ends blindly. The rules of septal alignment should also be considered in heart with the univentricular atrioventricular connection, along with the morphology of the main ventricle. In the heart, with the dominant right ventricle, then ventricular septum reach the crux, which means a regular atrioventricular node is present. When the main ventricle is the left ventricular morphology, then ventricular septum does not reach the crux cordis, so the connecting AV node is situated abnormally. These two drawings shows typical examples of a single ventricle, double inlet right ventricle and double inlet left ventricle. In the heart with the dominant right ventricle, ventricular septum reaches the crux, so regular posterior AV node is found, and the penetrating AV bundle is able to make connection with the inlet ventricular septum. When the main chamber is the left ventricle morphology, then ventricular septum is present like this, so which is does not reach to crux cordis here. So the connecting atrioventricular node is situated anterolaterally, where ventricular septum is in contact with the atrioventricular junction. The distribution of bundle branches relative to the ventricular septal defect depends on the position of the rudimentary chamber of right ventricle. If it rises to the right side, then bundle is located on the posterior inferior border. It's like a VSD isolated type, but it is the rudimentary right ventricle is the left side, then bundle branch is is located antero-superior border of the VSD. The spatial disposition of the atrioventricular conduction tissue in isomeric heart depends on the ventricular topology and the type of atrioventricular connection, following also the septal alignment rule in general. But all the right isomerism specimens generally have two AB node, an anterior and a posterior node, each give rise to separate AB bundle and join together, forming a conduction sling. So right atrial isomerism cases may be often associated with the atrioventricular reciprocating tachycardia mediated by two AB nodes. In left isomerism cases, single AB nodes usually found. Moreover, disconnection between AB node and the ventricular conduction axis is common finding in left isomerism. Therefore, atrioventricular block is usually associated with the left atrial isomerism.